Hi and welcome to this episode of the Presenter Series. It's my privilege today to welcome Julianne Day, who's a physiotherapist, text translator and teacher of the Stecco method of fascial manipulation. And to many of us here in Australia, fascial manipulation is something which has travelled under the radar for a long period of time. And it's one of the things that AAP Education is wanting to rectify. And I'd be the first person to say that yes, when I was working and training as a physiotherapist in my early stages, everything looked like it was a problem to do with the joints. Then when I came back from working in Canada and training in Canada for a few years, I considered a lot of people that were mobilising joints were actually massaging muscles. And now with a bit more awareness, I'm starting to also consider the involvement of the fascia, which is pretty much holding everything together. So today, Julianne's going to enlighten us from the perspective of a clinician and also a researcher and also involved in publishing papers, what this fascial manipulation is and how it can be used by us as clinicians to help our patients achieve better outcomes with their health. So I started by asking Julianne how it was that she did transition from being in Australia as a trained physiotherapist and ending up in a very romantic and lovely spot like Italy, still pursuing her career in physiotherapy and also coming across the fascial manipulation techniques.
How did it come about? I met an Italian and I married an Italian, and this Italian then wanted to move back to Italy, and so that's what we did. And having married an Italian back then, I was able to get Italian citizenship straight away. So that made things easier for me as far as work goes. And also, it wasn't that much easier getting my qualifications recognized. So that took quite a long time. But in the end, I did. And yeah, I started working here as a physio right from back in the 80s. And I guess I was doing all sorts of different things. I was interested in reflexology type techniques, and I had been asked to do some connective tissue massage, something that I'd done back in physio school in the late 70s, but I'd never actually put into practice. And so I was getting more interested in connective tissue when I met, I think it was 1991, I actually met Luigi Stecco. And I've just started writing a book about actually a little bit about the story of fascial manipulation and how it's been developed. But I do remember in 1991 talking to him at a conference and being fascinated by his ideas, but quite honestly not understanding everything that he was talking about. And that sort of got me curious. It wasn't until 1998 that I was actually able to do one of his courses. And since then, I've been involved quite heavily. I was asked to come on board, mostly, I think, in the beginning because of my English, because they didn't have anyone who was able to actually translate his work to sort of bring it out to the English-speaking world. And so that became my role in the beginning. And now that we have a lot more people involved who speak English, and so I'm now able to concentrate a little bit more on my own writing. But yes, I have translated 4 of his books, his textbooks, and I'm working on a revision of a 2nd edition at the moment. And I have been a teacher of the method since 2003.
Okay. So if we sort of look at the fascial manipulation as a method, most of our Australian colleagues probably don't have much, I guess, of an idea about what it actually entails, particularly in regards to the history of the method, how Luigi came to discover it, if that's the way to describe it. So how was it? Often there's a light bulb moment. Was there a light bulb moment in Luigi's case when he came to realise, hang on, there's something here that I'm seeing as a pattern and I'm kind of interested in eliciting what it is?
Yeah, I guess it was a slow process, but we can go right back to the early 70s when Luigi Stecco, Italian physiotherapist, was first studying. He was a student, a very curious sort of student, and he was kind of attending his anatomy and physiology lessons, but at the same time, he was looking around his local area, and he was living in what was then a rural area of northern Italy. There were people working in those areas that are called bone setters. Now, bone setters are found in lots of different cultures, right? They're unqualified, untrained people that have been taught orally by somebody, maybe their grandmother or their grandfather or their uncle, how to manipulate quite strongly soft tissues to sort of, help people with sprained ankles, sprained knees, etc. He was interested in their work because very kind of pragmatically, he said, this is a farmer's area that he was living in. And he said, farmers don't have time to waste. They're going to go where they get a quick, effective treatment. And so he was curious about what they were doing, but they weren't able to explain to him in anatomical and physiological terms exactly what they were doing. So he was interested right from the beginning in these sort of more vigorous soft tissue treatments. When he qualified as a physio, he started looking into osteopathy techniques, relaxation techniques, connected tissue massage by Dick as well, Syriacs. He was looking also into Travell's trigger points. But he really realized that it was probably the tissue known as connective tissue or fascia that was being worked on when he got introduced to Ida Rolf's work. Ida Rolf is the woman who developed a Rolfing technique.
German-based, is it?
No, Ida Rolf actually worked out of California. Now, she was in Esalen in the 70s, so it was fairly sort of non-scientific kind of work. In Rolfing, pretty strong soft tissue work, but Rolfing, it's considered to be a method in itself, but it's not necessarily practiced by, say, physiotherapists. It can be taught to people without that physiotherapy training, although some physiotherapists do Rolfing. But her explanations, once again, were a little bit anatomical, but a lot of it was fairly sort of intuitive, feeling, going with the flow type of thing. But he then focused on the fascial tissue, and he started studying other works by French teacher Bienfait, kinetic chains by another French teacher, Mézières. And he got to the stage where he, in 1987, published his first self-funded booklet, which was called Myofascial Sequences and Acupuncture Meridians, where in that book he traced a relationship between acupuncture meridians and kinetic chains, myokinetic chains, and he got focusing on deep muscular fascia. And at that stage, he'd already proposed that deep friction over specific points of deep fascia, mostly located over muscle bellies, could loosen connective tissue. And these were anatomically traceable myofascial sequences. Stecco did a huge amount of study of anatomy texts, looking at a number of anatomical texts. We have to keep in mind that Italy has been, since the Middle Ages, since the 1200s actually, one of the countries that have really laid down the basis for the anatomy that we know today. So he had a lot of access to Italian anatomical texts. He's integrated his studies about fascia and anatomy with his clinical experience, and he's developed a biomechanical model that relates fascial dysfunction to movement limitation, weakness, and pain. More recently, he's developed a different model for internal dysfunctions involving visceral fascia. In the end, Doug, we can say that his life work has been directed towards trying to simplify, I guess, the complex interrelationship that we have between fascia, muscle, bone, internal apparatuses, and systems.
When I've looked at the textbooks that Luigi has written and been involved with, it seems like he's very precise. He's spent a lot of time systemizing almost the process of how you would approach both in the assessment. So, like, I guess a lot of Australian physios understand that we're very systematized in regards to a Maitland's approach to how you would assess subjectively, objectively. And it seems to me that although the Maitland model isn't sort of used so much within Luigi's work, he again is a person that seems to have gone to great extent to very much systematize, have a process with a logical progression that enables patterns, I guess, clinical patterns to be seen and then perhaps interpreted, which would lead then to a treatment type approach. Is that how you would see it as well?
Yeah, I certainly with the method that he's developed, he's developed along with it a specific assessment chart. And this a specific assessment chart is helping the therapist to analyze fascial dysfunctions. It involves a subjective and an objective examination. So initial history taking process, followed by movement tests, followed by palpation testing. So we're always trying to hone in on the particular fascial structure which could require treatment in each individual patient. So physiotherapists are generally very comfortable with this type of approach. And the idea of using a chart as a GPS, that sort of helps you to work down to the areas that require treatment. And he has, and it's one of the mainstays of the treatment. So when people come to courses, they have to learn how to apply this assessment chart, and it uses method-specific abbreviations to fill in the assessment chart. That's a bit of a learning curve, but we've seen that.
Yeah, and they find that's a good method of collating the information that they are collecting, I'm guessing.
Sure, it's quite a step-by-step procedure, and it can help us to understand how previous problems can be related to present problems via the fascial continuity. We really have to take reference to the biomechanical model that Luigi Stecco has laid out and developed. So in the courses, we first teach the model, and then we teach how to apply the assessment process, making reference to that model. So it becomes important. Okay, yeah. So I was just going to say that it becomes really important in this method, the history of each patient, because we can understand how tensional compensations have developed over time. And clinically, most therapists have found that they are able to resolve problems that were previously perhaps resistant to treatment by following this type of reasoning process.
So getting back, so when we talked about how Luigi, I guess, came across the idea, did a lot of intensive and widespread study of anatomy, what would you say then are the concepts, like the basic concepts behind or underpin fascial manipulation that would be relevant to, say, a physio or a chiropractor's perspective?
Sure. So yes, he started to really, I say glean, because if you go back to your anatomy books, you'll find that anatomy books talk about fascia in bits and pieces, okay? Certainly when I studied in Adelaide, and back then it was a diploma in physiotherapy at the Institute of Technology, we did dissections, and we were told to cut away the white stuff so that we could get down to the muscles, okay? Yeah, the real stuff. Get rid of that white stuff there. And so in the anatomy books, they do talk about, however, how muscles do insert onto fascia, how parts of deep fascia extend onto adjacent segments of fascia. And so he did this enormous, cross-sectional study of anatomy texts, and he also delved into comparative anatomy. So going back and looking at different animal species and how their anatomical system has developed and where perhaps the connective tissue has been involved, and how he could work out, let's say, a way of joining all the pieces together. Okay, so if we think about the basic concepts, and because in Australia we're offering level 1 and level 2 courses, I think it's probably good to talk about the model that he's developed for musculoskeletal dysfunctions, because he does have a model for internal dysfunctions as well, but let's focus on the musculoskeletal. Now, if we add muscular fascia into the equation in terms of the musculoskeletal system, it really brings about a sort of a paradigm change in analyzing musculoskeletal dysfunctions, because we're no longer thinking about muscles with origins and insertions, but we're also thinking about the fascial component. Now, we can say right from the beginning, he discarded individual muscles as functional units, and he focused on motor units. Understanding of physiology, which is true, is that, really as motor cortex doesn't think about muscles, it thinks about a continuous flux of motor units that are being turned on and turned off according to the degree of joint movement, direction, and force required. And so if we focus rather on motor units and their relative muscle fibers, we know that if a motor unit activates its connected muscle fibers in an all or nothing manner. But it's curious that these muscle fibers connected to one motor unit are not always adjacent to one another and can even be located in different muscles. So thinking about this, Stecco realized when we're talking about motor units, we're talking about a single alpha motor neuron that activates any number of muscle fibers according to the degree of accuracy or precision that's required from that particular anatomical region. Switch our focus from entire muscles, and we know that entire muscles hardly ever are activated altogether unless we're doing a very strong resisted movement. Okay, most of our daily activities are turning on and turning off motor units, so activating parts of muscles, okay, according to the direction we want to move in and the amount of force that's required. And so Stecco's shifted focus from entire muscles to motor units, and he realized that the fascial skeleton. Now, if we talk about the fascial skeleton, what are we talking about? We're talking about, let's focus in on how each single muscle fiber is surrounded by its endomysium. Groups of muscle fibers within a muscle are surrounded by perimysium. An entire muscle will be surrounded by its epimysium, and perhaps around an entire limb will have the deep fascia. Now that is, we could focus on that as a type of fascial skeleton, if you like, connective tissue surrounding each part of the muscle without any break between. There's a continuous connection between all those tissues. So he realized that this type of fascial skeleton within muscular tissue could be the uniting element that actually connects together all those various muscle fibers from single motor units. Okay, does that make sense?
Yes, yeah. So we're looking at a much smaller unit of interest as opposed to a gross muscle, and then we're also looking to
Yes,
see whether there are linkages between what sort of specific fascial linkages between those muscle fibers that are linked back to the same alpha motor neuron.
exactly. But then, obviously, when we move, we'll be activating probably several motor units to move a body part in a specific direction. It won't just be one single motor unit, okay? In fact, he decided that was probably just to be able to understand how could the fascia be fitted into the musculoskeletal system. He decided that we could perhaps interpret our musculoskeletal or myofascial skeletal system, if you like, in terms of what he called myofascial units. Okay, and so this is the baseline of the model as a myofascial unit, and so if we have each myofascial unit, we have motor units innervating monoarticular and biarticular muscle fibers. The joint that these muscle fibers will move when they contract, and if we can kind of collocate together the ones that work in one direction on one plane, then we can simplify our understanding of it. We have the nerve components that are involved in this movement that activate the muscle fibers, but we also have the deep fascia and all its derivatives, the epimysium, the perimysium, the endomysium, which unite all those components together. So we have a myofascial unit. Okay, so one myofascial unit is made up of any number of motor units, all working to move a body segment in one direction on one plane. It's a simplification. It's clearly a model, okay, to help us to understand how the fascial system could be working. I'll just give you one example. So if we think about elbow extension, and we think about how the myofascial skeletal system is organized, we have our joint component, which is the elbow. We have the deep fascia and its derivatives, epimysium, perimysium, of the posterior upper limb that's forming the fascial component. The muscular component is formed by fibers from medial and lateral head of triceps, as well as so they're the monoarticular components, and the biarticular components are formed by the long head of triceps. So Stecco realized by studying his anatomy that throughout the body we have this same repetitive formation. So he considered that the myofascial unit could be like the building block of the myofascial skeletal system. He realized then that when muscle fibers within a myofascial unit contract, they're going to convey tension towards a central point, or converging tension. It's possible for the tension to converge to a specific point. And he called that point the center of coordination. It's mostly found over the monoarticular component of each myofascial unit. He also has other terms that he uses referring to the myofascial unit, but as therapists, we're searching then on the deep fascia for these centers of coordination. The centers of coordination of a myofascial unit is generally where, let's say, the deep fascia is subject to change because it's an area of convergence of tension. Now, it's because the tension from a myofascial unit can converge to a specific point because of the way that the fascial system is structured. Part of it is free to glide over the muscle, part of it is attached to the muscle quite strongly, and part of it is attached to bone. So we have a three-dimensional system that's able to create tension that converges in a specific point. This is obviously the theory. So from transmitting from those series. So if we break down to the smallest item of the model, it's the myofascial unit. Myofascial units that work in one direction or one plane are joined together by their biarticular component, and that forms structures known as myofascial sequences. Obviously, we don't just move on the 3 planes of space, and so there are other areas of deep fascia that Stecco has identified, which is called centers of fusion. And they're monitoring movements in intermediate directions between 2 planes. So from a therapist's point of view, we have a topographical map that Stecco has developed over his 40 years of study that we can follow to work out which areas of the deep fascia are most likely in our patient not going to be sliding, gliding correctly, and that's where we go and apply our deep frictional massage.
Okay, so we're looking for fascial convergence, often where there's a transition or a force of some sort that is in the monoarticular components, and that's the center of fusion.
Center of coordination.
Center of coordination, and that tends to be the monoarticular structure. So medial and lateral head of triceps would be one example, like you gave. And I guess also vastus medialis, vastus lateralis, and intermedialis, but not rec fem.
Not so much, no. Each myofascial unit has a center of coordination which has a specific anatomical location. And these locations or these points are what people learn on the courses, where they're located, how to approach them with the best type of manual approach, how then to treat them in a balanced combination.
And that's probably dealing with the more simplistic 3 cardinal planes, and then when you get a bit more skillful, you start to move into the center of fusions, where you're looking at the same concept but more on an oblique type planes.
Exactly. In fascial manipulation courses, we've divided the courses into different levels. So on the first level, participants learn the location of the centers of coordination, how to treat in a balanced combination. Yes, I'd say the more simpler types of cases, but certainly it's a huge amount of our daily caseload. On level 2, we move into then understanding how to integrate into that the work on centers of fusion. Now, if we think about centers of coordination and we're working on planes of movement, each myofascial unit is then connected to the next by its biarticular component and by fascial expansions. So we have myofascial sequences. So you can imagine that in a treatment, I might be working on one plane, and I'll be working up and down on that plane to find the area, the centers of coordination on that plane that are densified. When we get into working with centers of fusion, we're looking at more complex movements, so movements that are on multi-planar movements. And so obviously that's a huge part of our caseload as well. We then find that centers of fusion are located on what Stecco has called structures such as myofascial diagonals and myofascial spirals. So we always have a sort of a pattern that we are working with in each individual patient. So the art, let's say, of the method is to analyze that individual patient, work out which particular pattern requires treatment, and go ahead with the treatment on that structure.
You mentioned when you say we're palpating for a plane, say the sagittal plane, that you'd palpate the centers of coordination that were densified. Yes. Are we talking about a palpatory technique where you can feel a tissue change? That's what you're looking for?
Yes, in fact. I find that funny that the term densification didn't actually exist in English. When I was translating Stecco's work, of course in Italian it's densificazione, and I thought, goodness me, how am I going to translate that? And then I thought, well, we do have dense, we do have densified, let's just make it densification.
Dun, dun.
And so I find it really funny when people start talking to me about densification. I think, hey, that's a word I invented. But I still haven't found it in a dictionary yet. But certainly in fascial terms, we're talking about something called densification. Now, it sounds a bit vague, but we certainly have a lot more studies now to help us understand exactly what we're feeling when we palpate tissues that are not sliding or gliding. Now, yes, we're looking for densified tissue, and according to the Stecco model, it becomes specifically important when there are these key areas known as centers of coordination or centers of fusion. And densification, there's been a lot more histological studies over concerning deep fascia in particular, and so we have a much better idea of exactly what we are feeling and what might be happening when we start working over these points.
Okay, so let's take a break now, and we'll come back and talk about some of those studies that you think are important in regards to the evidence of the efficacy of the Stecco method.